A privilege to be here and to have the benefit of such insightful conversations and discussions that we've had to date. For the last number of years, I've been deeply involved in a foundation that I created called Access Health International. Our goal is to serve as a think tank, an advisory group, and implementation partner for health systems. One of the ways we exercise that is, first of all, to look around the world for very efficient health systems, learn what we can for them, and help those in governments or the private sector that are interested in improving their health systems, their health practice, or creating new businesses. I had the privilege of working very closely with a number of people in Singapore. I wrote a book on the Singapore healthcare system. Jeremy Lin was both a collaborator and a critic. He wrote his own book on the Singapore healthcare system that came out just a few months after mine. And I think together we have put together a very interesting picture of one of the most efficient healthcare systems in the world. It delivers very high quality health at a cost of the government of about 1.2, 1.3% of the GDP. Which is astounding if you think the US at about 11% of our GDP, and you think of many countries at 7 or 8% of their GDP, and the results are spectacular. And as a scientist, I always look at proof of principle. For the last few years, we've been looking at other kinds of systems. And I was surprised to find a really impressive story right under my nose in New York City. It's a story that surprisingly is very little known, at least up to now. One of the reasons is, I think, because New York is such a competitive place that when you raise your head, you get it chopped off by your competitors and by the press. So it's a story of a healthcare system transformation. Like many stories of positive outcomes, it begins with trouble. New York University Medical Center, which includes the full range of activities from education, research, and patient care. And it's divided into two sort of separate systems. One, of course, is the medical school, the other is a hospital. Over a period of time, began to sink in reputation and sink in financial viability. And about 10 years ago, 12 years ago, it got in such deep trouble that the university was afraid it would sink the whole university because the cost centers of medical care are enormous. And the cost was, the losses were substantial. They were running $150 million a year or more. They were made up temporarily by the income from a spectacular product that was invented by one of their faculty that brought in over $1 billion in revenue over time. That, of course, comes to an end with patents, and they could foresee a time. And their first impulse was to get rid of the medical school and the hospitals to insulate themselves from the problem, which they tried very mightily to do by merging with Mount Sinai. Well, the medical school rejected that, and the hospitals merged, and very quickly, within 6 to 9 months, realized the merger was a failure. And then they had to bring it back, only they brought it back with another $500 million worth of debt. So on top of their loss-making operations, that's a pretty bad scenario. Their back was against the wall. But they had a couple of advantages. And one of the things I look at in this book I'm now writing is how you take a situation like that and really turn it around. I'll just give you the numbers today. 10 years ago, they had revenues of about $2 billion if you include the medical school, and they had losses that I just described. Today, they have revenues of about $6 billion, and they're making about $600 million a year in profit. Now, they don't call it profit, they call it surplus, because it's a not-for-profit organization. And you can imagine if you cut costs, cut quality, you can make profit. But that isn't actually what happened. They were, in those days, ranked 60 out of 120 of academic medical centers in quality and safety. After 5 years, they are now ranked number 1 in the country for quality and safety, and have been for the last 3 years. Number 1 in the country. So that's something. You improve. They've expanded. They haven't shrunk from 7,000 employees to 27,000 employees. Now, an academic medical center has 3 primary missions: taking care of patients. They've done very well at that. The second one is education. They were ranked not very highly on the medical school rankings. They were down around 39 or 40. Today, they're ranked in the top 10 medical schools in the country. That is an amazing transformation, one that hasn't happened in any other university so rapidly. And in terms of research, which is their other measure, one good measure is how many research grants you get from the National Institutes of Health. They were ranked about 45. They're now ranked about number 11 or 12. It's an amazing transformation. And the question is, how did they do that? Because it's something that hospital systems would like to do. It's something that medical schools would like to do. It is something that research institutes would like to do. They'd all like to improve their rankings. And as you look around the world, you see a tremendous interest in developing high-quality healthcare at affordable costs. So what was the magic secret? What did they do? That's what this book is about. And I'm not going to talk about all the things they did, but essential to what they did is a real-time, comprehensive information system, one that measures every single thing that happens in the hospital system. So they have put in, and they did it as one of their highest priorities when they hired a new CEO for both the medical school and the hospital. And again, that was a very important part of the transformation. You say, we're not going to have a dean for the medical school and a president for the hospital. We're going to have a single person. We're going to treat this entity, even though the details of its composition are more complex. We're going to treat it as a single unit. And we're going to manage it as a single unit. And we're going to look at all the information that you need. And when the CEO came in, Bob Grossman, he was a radiologist, he asked, where's the information I need to manage this entity? He said, I don't have it. He asked his head of informatics, where's the information on patient outcomes? Where's the information on finances? And it was all bits and scattered pieces. There's a very interesting story told to me by the man who actually implemented the information system. And after asking the head of informatics at the hospital for help, didn't get it. He said, I'm flying a 747 blind. A few months later, he said, now I'm flying the 747 and I'm sure it's crashing. There's a mountain ahead of us. Where's the information I need to pull out? A guy 2 levels down, he's the guy who installed the equipment and really worked with all the different sections in the hospital and the medical center. He was responsible for the infrastructure. Came to him and said, I can help you, but I have a condition. And he was a pretty brave information technology guy, both to go over his boss's head and to the big boss and say, I have a condition. What was the condition? That I meet with you personally with none of your direct reports. So he went over the heads of all of the direct reports, which are all the vice deans for research and hospital care and CEOs and everything else. He said, because they're your problem. And after about 4 years, very diligent work, working with a number of groups, including incorporating EPIC, the first time EPIC really worked with an academic medical center, they created a data repository which contains real-time data for everything that happens in that academic medical center, whether it's garbage collection or how many units of blood are used for an individual operation. And They have a very definite rule that nothing can happen in that entire academic medical center unless it's digitized. Not a single piece of paper. It's totally digital. And it has to be compatible with the data repository. I'll give you a very specific example. They wanted to hire a top cardiologist. The cardiologist insisted that if he were hired, he was going to bring his own information system with him, his own technologies. They weren't compatible with the data repository, so he wasn't hired. If there is a piece of equipment that performs in a superior fashion, let's say they're a total Siemens shop, which they happen to be, not a GE shop. GE had the chance, but blew it. If they want to bring in a piece of GE equipment, they can't do it because the number one overriding concern is information clarity. The reason I think it worked is they had a CEO, who was a radiologist, who understood the power of unified information. And he wanted all the information he needed to achieve his strategic objectives, his vision, and a very clear articulation of a strategy which would get him where he wanted. He put on a single piece of paper, which I've seen, and it's available at a Harvard case study for one particular aspect of what he did, a complete integrated vision of how he wanted to get from where he was to where he needed to be. And central to that was total information clarity. He now has a dashboard. And it's a dashboard like I have never seen before. He is a virtuoso of the dashboard. So it's the reason I got interested in the story. I asked him if you were interested in expanding to other countries. He said, absolutely not. We're just focused on what we're going to do. We're focusing on our own expansion, our own efforts here. But let me show you what I can do. And he began to show me the dashboard. He said, let me show you, for example, how many people are right now in the emergency room. With a click of a button, you see there are 8 people in the emergency room, and you have how many minutes each one has been waiting. And every minute it updates. He says, let me show you something else. We're very interested in the cost of materials that go into our surgery. One of the most costly materials is blood. How many units of blood do we use for hip replacement surgery? He shows you. How many units are used by each surgeon for the same type of surgery? And they're all listed. One is using 4 times as many units of blood as the other for the same surgery. What happens? They counsel that person. That person either reduces an amount of blood that they're using or is no longer in the hospital system. So they have a very strict accountability. They ask how many infections we've had, and they have the national standard. They have where they are. They can show the charts of what happens over time. They can then go for individual units. Let's look at orthopedic surgery. Let's look at cardiac surgery. Let's look at each patient. Let's look at the patient record. Why was this person infected? Is there a reason? Were they in some horrible traumatic accident where they're filled with bits of concrete and asphalt? Or was it just something else? How many days does each physician have for hospital stay? How many of their patients return for subsequent treatment? When they wanted to do something, for example, they wanted to get their patients out by noon that were in the hospital so they could get new patients in and save a whole day of hospitalization. That happened. And so what they did is they broke it down by nursing ward. They talked to their nurses. What happens with medical education? They've gone, as I mentioned, from a relatively mediocre status to one of the top 10 in the country. What they decided to do was digitize as much as possible medical education. You can go online today and find some of their digitizations. You can find the digital human. And there are other sources of that, but we heard how you can do some digitization. You can see digital anatomy. You can go through a complete anatomical examination of, they also have virtual dissections. They have digitized pathology. So you have over 3,000 pathology slides which you can navigate by Google Earth. They actually put the Google Earth software. So you can, and if you know anybody who used Google Earth, you can tag things. So the professor can tag, or you can ask questions and get answers. So it's a tool. They have created a very interesting educational program which measures not just time of progression for their students and their graduates. They actually measure competency all along the way. They measure competency in sim labs. They measure competency through a series of online exams. They measure competency when you have not just a simulated patient who's an actor, but let's say a maternal bleed out, and you've got to work as a team to solve the problems. They measure your competency there. They're even measuring competency now using these digital tools and feedback for their new entries of their graduates, their residents, before they let them onto the wards. And they find no matter how good the medical school they've come from, they don't all pass. About 20% don't pass. So they have to re-educate them before they let them onto the patient wards. When it comes to managing research, research is a very difficult thing to manage. It's actually, if you read management books, when they come to manage researchers, they just basically throw up their hands. What are we going to do to manage these unmanageable people? You know, I saw one management book where they compared us researchers to chickens. One chicken, unhappy. 10 chickens altogether, very happy. That was their management solution. Well, what they do for this, and you have to realize they had come from a position, not where they were Harvard, but where they were an old-fashioned research institute where they had a lot of dead wood. They put in some very strict metrics. You've got to, if you're going to stay and keep your salary and keep your space, you need to have 3/4 of your salary paid for by grants. And if you don't, you get your salary reduced. You get your space reduced. Now, all of you who've gone through academia understand that that could lead to some unhappiness. And it did lead to unhappiness. It led to a lawsuit, which they won. They were sued by the professional organizations, and they actually won. They don't take away tenure, but they take away benefits if you don't perform. They also make it totally transparent as to how everybody's operating. From a doctor and their outcomes, anybody can look at the infection rates, return rates to the hospitals. It's all available. And every researcher can see what every other researcher is doing in terms of grants. Well, that draws upon our competitive nature. And it turns out it's a very positive effect. I can't say, and you could never say, I think in any organization, that it's the information system alone which enabled these remarkable changes. But without the information system, it could not happen. There's a couple of things that are really important, and this is getting to the stone soup. You know, it may not be the rock, but it's certainly the pot. And then what you put into it really matters. What I mean by what you put into it in this case is human engineering and process engineering, because they would be the first ones to tell you that as important as the information system is working with the people at all levels, whether it's the nurses, whether it's the maintenance people, the purchasing people, the finance people, the surgeons, the nurses, the nurse practitioners, to make sure that they have the processes they need to enter the data and to understand and to use the data as it can best be used. It is not a natural process. It's actually an unnatural process. but they put at least as much effort or more into how you train people to use this data. Now, in the final minute, let me just say an extension of this system. What this also allows you to do, it allows you to have complete clarity. The way they make their money is to use this system not to manage their hospital, but to create outpatient clinics. 95% of their profit comes from their 200 outpatient clinics, not from their hospital. But without this information system, they couldn't begin to develop this distributed care model. And this is step one. Step one, get the hospital operations profitable. Step two, build a massive, right now, 5,000 member doctors in outpatients and do almost everything you can, including brain surgery outpatient, in the morning, out at night, which is enabled by this information system. And the next step, which they're now taking, is community care. They're now moving from outpatient clinics to community care, and they've purchased 2 large safety net hospitals. And it's possible to do it and to manage it and to make it profitable by using these information systems. And I think if you look at where health systems can go, and what we do now as a foundation, is now we have this deep understanding of how you use information to help hospital systems, help countries, and help businesses institute these kinds of information systems and human interface systems that can render a hospital system or a country's healthcare system efficient and profitable, or if not profitable, cost savings. So with those, I'll finish up, and hopefully I finished on time.
Thank you.